So where might this be used? Early detection, we've identified a couple of cases, example cases, where early detection would come into play. So ovarian cancer and prostate cancer are two clear examples where today there's no good way at an early stage to identify cancer. You might say breast cancer would be a good example, but the problem with breast cancer would be the length of the clinical study that would be required to compare to, for example, a mammogram. But there are applications, the one I described a few minutes ago about the HER2 spread to the lymph nodes. So instead of looking at actually identifying breast cancer as the primary diagnosis, what if we could use our technology to stage the cancer? And I'll go through this in a second. And then there's always the opportunity to look at therapeutic monitoring. So if I now have a patient where I've identified that there's a tumor, can I go then use our nanoparticles, attach them to the cancer cells, start to treat the patient, and what we should see is a reduction of the nanoparticle signal, right? If the cancer is getting taken care of by the therapy, we should see a reduction in the signal. So we have opportunity with our technology to do primary diagnosis, cancer staging, and potentially therapeutic monitoring of a patient. So let's just look at three examples and sort of the market opportunity with those three examples. Today, ovarian cancer is very hard to diagnose early. Most ovarian cancer is asymptomatic until it gets to about stage 4. What happens is women are typically screened by a blood test for CA-125, among other things. But the problem is that CA-125 is not specific to ovarian cancer. There may be multiple reasons why CA-125 might be elevated. So what the docs do is they do something called watchful waiting. If you have an elevated CA-125 blood count and you have other heritable or other reasons, risk factors, they want to see you every 6 months and look at by transvaginal ultrasound. The problem is that transvaginal ultrasound needs about 10 million to 1 billion cells before it's able to identify it. So by the time ultrasound sees the tumor, it's stage 4. If I could take a patient who has CA-125 elevated blood count with other risk factors and give them a dose of our particles and identify that the cancer is actually there, now we have an opportunity to do something earlier. Exact same thing, go to the far side, exact same thing, mostly men in this room. I don't know how many have had a prostate biopsy before, but you have an elevated PSA count. They don't know what else to do, so what do? They stick your prostate with a needle 12 times in hopes that they can find the cancer. If we could take a patient who has an elevated PSA and give them a dose of particles and now just do a measurement and say, yes or no, we can find cancer cells in and around the prostate, I now have a non-invasive way to detect the presence of cancer earlier. Now I have a reason to go in and do something surgically as opposed to just a sampling method. And the last example there was the one I talked about earlier, which is spread to the lymph nodes. I don't want to try to identify the primary tumor. I want to be able to help the doc before you go do anything surgically, before you go remove the lymph nodes and do lymphodectomy, or before you do a series of needle biopsies, can we just give the patient a dose of particles and tell them whether or not it's spread to the lymph nodes?